The nurse is telling the jury how child B stopped breathing around 12:30 am on a night in June 2015. The baby, which survived, broke out in similar whitey purple blotchy patches to child A. Quote, "I just thought, no, not again," the nurse told the jury. Notes from that night show how an emergency call went out to doctors. Child B was placed on an infant resuscitator and medicines administered. Within about 10 to 15 minutes, child B began to improve almost as quickly as she had deteriorated. LucyLetby's defence barrister, Ben Myers KC, is now questioning the witness. He asks her if there were times when the Countess of Chester, during the period of June 2015 and June 2016, was, quote, just too short-staffed. Yes, the nurse replies. Mr. Myers is now asking the nurse about the circumstances of child A's death. He asks whether she had been made aware, when starting her shift, that child A had been without fluids and medicines for several hours due to various tubes being out of position. Possibly, she said. Circling back to the nurse's description of, quote, white and purple patches, Mr. Myers points the jury to past statements made by the witness to police in 2018, which make no mention of such patches. Asked to explain why they're mentioned now but not then, the nurse could not explain. Mr. Myers puts it to the witness that these descriptions of patches have come from subsequent discussions with other staff, rather than what was actually seen on child A. The jury is now hearing evidence from paediatric registrar Dr. Rachel Letby, who was on duty the night child A died. Dr. Letby is taking the court through the emergency crash call she got after child A fell ill. Dr. Letby recalls arriving in a neonatal intensive care unit as medics were attempting to resuscitate child A. After 30 to 40 minutes, the decision was taken to stop. Paediatric consultant Dr. Ravi Jairam is now giving evidence. He is taking the jury through his recollection of the evening child A died. He says the baby's deterioration, quote, didn't fit to me with any disease process that I have seen, learned or read about. Dr. Jairam told the court that when he raised initial concerns about Miss Letby, he was told, quote, not to make a fuss by senior managers. He said he wished he had been more courageous in reporting his concerns. The trial is now resuming with someone who was a consultant paediatrician at the time of June 2015, giving evidence in court in relation to child A and child B. She said she, quote, cannot recall the events for child B's collapse at 12:30 am on June the 10th, as it was 7 years ago, and her recollection would be based on the statement she had given to police. The court is shown clinical notes made by her, written retrospectively at 2:40 am on June the 10th, 2015. She was called at home at 12:36 am and arrived at the neonatal unit at 12:50. She recorded child B, quote, went apneic, stopped breathing, followed by sudden purple blotching of body all over with slowing of heart rate. The consultant says the purple blotching would have been the registrar's account of events relayed to her. The registrar also relayed child B was bagged and tubed and the heart rate went up with adrenaline not required. The consultant noted for her observation, quote, upon my arrival, purple blotching right mid-abdomen and right hand. The baby was pink and active. The prosecution asks, do you have any independent recollection of that now? The consultant replies, no. The consultant relays the various medical observations that were recorded at the time, including blood gases, protein levels and heart rate. The consultant tells the court discussions have been ongoing since the evening of June 9th in the light of child B's twin brother dying on whether child A and or child B had been affected by the mum's blood condition. Consultants at Great Ormond Street Hospital had said they, quote, did not feel the mother's condition would affect the baby in any way, while consultants at Alderhay Hospital suggested further blood tests being carried out. Following child B's collapse, the blood observations taken were good and meant the requested extra tests were held off. Child B was restarted on antibiotics as a precaution. There was still concern her circulation had to return to normal, so the consultant noted more fluid was administered to help with that. The consultant's notes add, spoke to parents, purple discoloration almost resolved, ? Cause. The consultant says from looking at her notes, she was quite puzzled by that as there were 2 question marks. The notes add, stabilised at present, continued antibiotics, nil by mouth, repeat gas and wean as tolerated. The notes conclude for further tests to be repeated at 7:30 a.m. at the end of the night shift. Ben Myers KC, for Letby's defence, asks about one area on the clinical notes talked about. Mr. Myers asks about the purple discoloration, and that by the time the consultant had arrived, she had noted what she had seen at 12:50 a.m, and had, quote, almost resolved by the time of the note at 2:40 a.m. She tells the court, quote, I think this was something I was puzzled about and wondering what it would be. She says other causes were ruled out as such a rash had come out of nowhere and had almost completely gone a couple of hours later. She added she was, quote, a little bit confused and was trying to put in place all the safe things she could to treat child B. Independent medical expert Dr. Evans has returned to give evidence in respect of child A. He confirms he has written 4 separate statements in respect of child A, the latter 2 being clarification on technicalities. The first report was written in November 2017, the second in May 2018. Dr. Evans said he became involved in the case in July 2017 by the National Crime Agency. He visited Cheshire Police where they had concerns about a number of deaths in the Countess of Chester Hospital, which were, quote, unusual and far more deaths than they would expect. The deaths had followed collapses in babies which were otherwise quite stable and involved collapses where resuscitation attempts were not successful. He said, quote, I thought I could help advise, review case notes and form an opinion that led to the collapses of child A and child B. He said, quote, despite the prompt resuscitation in child A's case, child A had died despite doing very well. He said his job was to look at the clinical evidence. He added that child A was the first case he looked at, and subsequent reviews of other children had reinforced his opinions for the conclusions of child A and child B. He said, quote, a pattern became apparent in the cases, which he described as quite disturbing and quite unusual. For child A, Dr. Evans confirms he had received clinical records for the baby boy to review and had received statements from Countess of Chester Hospital medical staff for the case. Dr. Evans explains to the court certain medical procedures such as cannulas, UVC and long lines. Dr. Evans said there is a connection between the insertion of a long line and cardiac tamponade, where fluid obstructs the heart and is a deadly serious condition. He added that sadly he was aware of a case which happened in Swansea, where a baby had died as a result of that. He said such cases are where a long line has been in place for several days. Diagnosing such a condition post-mortem would also be relatively straightforward, as fluid would be detected outside the heart. For child A, he had not come to the conclusion that cardiac tamponade was the likely cause of death. Dr. Evans says from looking at Dr. Harkness's clinical notes at the time, the efforts to save child A were, quote, very good standard resuscitation procedures. He added, it is what you would expect in any neonatal unit in 2015. Dr. Evans said, just before child A's collapse, he was in a stable condition. In his report, he had described his condition as perfectly satisfactory. He added, quote, he was as well as could be expected. All the markers of well-being were very satisfactory. He was in air, not needing additional oxygen, heart rate in normal limits, oxygen saturation normal, it had been in the 90s, respiratory rate slightly above normal rate, but that was the only marker outside normal rate. He said child A had survived the most dangerous journey of his life, and although he needed care for feeding himself, he was doing really, really well, and everyone on the unit would have been really pleased with how he was. Dr. Evans said he had not been presented with evidence of the discoloration as the court has heard through this trial for child A. He said it was not noted in the evidence he had received. He adds, quote, I think the rash in child A's collapse fits together and fits a significant diagnosis of air embolus, injection of air into the circulation. He said, quote, "Somehow air had got into the circulation. I found this opinion without knowing about the rash and without anybody suggesting or expressing concern of air embolus." He rules out other conditions such as sepsis, a lack of fluids or hypoxia as causes or contributing factors to the collapse. He said he had only one conclusion, that child A had received an air embolus through an IV line. He said with the systems in place and the medical equipment and medical staff being obsessive about making sure patients are not injected with air, there was no way this could have been done by accident. Dr. Evans will be cross-examined by the defence after giving evidence for child B. Before that, independent medical expert Dr. Sandy Bowen has now been called in to give evidence for child A. She is detailing to the court her medical and professional background. Dr. Bowen says she was asked to peer review Dr. Evans' report and was to find whether she agreed with them, disagreed with them, or had additional findings to present. She has also considered other findings from other independent experts in the case. The prosecution asked Dr. Bowen to clarify whether she had also seen a post-mortem report for child A and the reports of Countess medical staff. She confirms that was the case. Dr. Bowen explains child A was, for a baby born 10 weeks premature, a stable baby, on breathing support via CPAP but not requiring oxygen ventilation, and was doing so well that medical staff decided to start giving him some feeds. Quote, "If he was unstable in any way, they would not have done so," she tells the court. The UVC placement and longline placement did not have any contribution to child A's death, Dr. Bowen tells the court. Was the stopping of breathing for child A caused by his prematurity, the prosecution asks. Dr. Bowen said it could be ruled out as there were no previous episodes, and caffeine had already been administered to counteract it as a precaution. The discoloration seen, while seen in collapses in other infants, did not explain the pink blotching that came and went in child A, Dr. Bowen tells the court. She says the only plausible explanation for child A's collapse is an air embolus. Dr. Bowen said doctors and nurses are absolutely meticulous in making sure even the tiniest air bubble is not injected by accident into a patient's circulation. She adds that even if air was accidentally administered, there is an electronic pump system which would detect the air and stop the administration. Dr. Bowen explains to the court that could be bypassed further down the line by administering the air embolus via a connector normally used for administering drugs. Dr. Bowen is asked how much of an air embolus would be considered fatal to a child of child A's size. She says that 3 to 5 ml of air per kilogram of body weight could be fatal. She explains child A weighed 1.6 kilograms, around 3.5 pounds. A teaspoon of air, Nicholas Johnson KC prosecuting asks. Well, that is 5 ml of air, so yes, replies Dr. Bowen. Mr. Johnson prosecuting asks, what, in your opinion, killed child A? Dr. Bowen replied, child A was killed by an air embolus. Dr. Evans is recalled to give evidence for child B's non-fatal collapse. He said the collapse was not really likely, as all the markers were satisfactory, and the medical staff had felt comfortable enough to allow the baby girl to be out of the incubator for a short time so she could be handled by the mum. He said that was not something you would do if the child was not stable. He said the two conclusions he had for child B's collapse were smothering or an air embolus. He said the discoloration was a striking feature which had been seen in child A. It arrived and went very quick. He said if the rash was associated with other conditions, it tends to stay. Dr. Evans tells the court the collapse was very similar to that of child A, but what happened was less severe. He said either the volume of air injected was less, or the volume of air in the circulation got there more slowly, or a combination of the two. Asked by Mr. Johnson if there were any other possibilities to the cause of the collapse, Dr. Evans replies, I could not think of anything else. The doctors did a really good job in saving her. There was no evidence of sepsis, problems with the lungs, nothing unusual about the chest x-rays, lungs were full of air, nothing else to explain this collapse, which again was sudden and unexpected. He added, quote, we have heard numerous doctors saying they have never seen this before. I feel I can say the same. It's very unusual. Ben Myers, KC, defending, says Dr. Evans has prepared, quote, a large number of reports over the years, and air embolus feature in a number of them, literally dozens. Dr. Evans agrees. Dr. Evans is asked to explain the features of an air embolus. He adds, quote, an air embolus will lead to a sudden and unexpected collapse. A patient otherwise stable collapses, and by collapse I mean change of colour, stops breathing, reduced heart rate and death. This occurs all of a sudden. There are additional features, and you don't get all of the features in all cases. The two main associated features are unusual skin discoloration and the presence of air in the great vessels. Those are the compounding features which lead to a diagnosis of air embolus. This occurs when there is no other explanation which fits the collapse, and when resuscitation is unsuccessful. Resuscitating patients for doctors is part of our bread and butter, so resuscitating is well known. When that is unsuccessful, it adds to the confirmation of an air embolus diagnosis. Dr. Evans relays one case of a baby who had died in Swansea from an air embolus from what should have been a regular surgical procedure. He said he had not been involved in the report, so was unaware of any discoloration in that baby. He says he has never come across such skin discoloration in a collapse in hands-on experience. That is something I am relieved and pleased about, he said. Mr. Myers, on behalf of the defence, said the diagnosis is one of exclusion, ruling out alternatives until there is one explanation left. Dr. Evans said there is more to the case than that. He said his original conclusion was without knowing about the skin discoloration in child A. He adds that if you discover additional information, that simply firms up your diagnosis. Dr. Evans states that air embolus cases are difficult as there are isolated case reports and the systems are put in place in modern times so the conditions are not repeated. That is not a criticism, that is a compliment, hence there is very little new research, he said. He adds that doctors may be reluctant to spread news of mistakes in cases where there may have been an air embolus. Dr. Evans said he was tasked with investigating a clinical condition, not a crime, when he became aware of the Countess of Chester Hospital case, when tasked by the National Crime Agency. He said the scenarios added up to a, quote, constellation of worries on what went on between June 2015 and June 2016. He adds that in past cases, he has been brought in by police and the conclusion was accidental, so the case was closed with no further police involvement. He is asked about his state of mind in his approach to the cases. He said, quote, my state of mind was very clear. Let's find a diagnosis. Nothing to do with crime. Let's identify any specific collapse and see if I can explain it. There were occasions where I couldn't explain it, and occasions where I found something deeply suspicious. There were instances I found disturbing. He was asked to investigate 33 cases in total, with 2 insulin cases later. He said there were 2 babies who were born in unsurvivable conditions with obvious medical diagnoses. He said, quote, the name LucyLetby meant nothing to me. I didn't know the staff. I was the easiest physician and the most difficult. I was a blank sheet of paper. I had no idea and relied entirely on the evidence I could see from the clinical notes and applying my clinical experience and forming an opinion to the cause. He said he asked to have one case file to have an idea of what he was dealing with. Mr. Myers, on behalf of the defence, asked, was the phrase air embolus used at all? Dr. Evans replied, no, the first person to use air embolus as far as I was concerned was me. I need to give the NCA a compliment, they never gave me a steer. They are good professional people. Mr. Myers turns to the case of child A. He asks that preterm babies such as child A are prone to complications. Dr. Evans replies, that is why we have neonatal units. He adds that the care he received meant he had overcome the most difficult parts of his life and was stable prior to his deterioration. Mr. Myers asks if child A was, quote, perfectly satisfactory prior to the collapse as according to Dr. Evans' notes. Dr. Evans says he does not want to engage in semantics, but adds that for a preterm baby in a position he was in, child A was satisfactory and really good. A clinical note is presented to the court with a number of problems listed. Dr. Evans replies, I would call them issues, not problems. That is what any competent junior doctor would list as the issues present. We have got to deal with the fact he is preterm. He has breathing support, we need to establish feeds, there are concerns over suspected sepsis. Any doctor would write things down. An X-ray review is presented with the note RDS, Respiratory Distress Syndrome. Dr. Evans is asked about that comment. He says, quote, "I have seen the report. It's not too bad actually. That is why we put babies on CPAP." A blood gas record showing a high number for lactate, 2.6 outside the range up to 2, is shown. Dr. Evans explains he wouldn't be particularly concerned at such a reading, as he says 1 or 2 readings would be outside the normal range. He describes the reading as marginal, with all other readings normal, and child A was handling well. He said he would not interpret an oxygen reading from a capillary sample from a heel prick. He says if he saw such readings, knowing if the baby was in air, he would not be rushing to stick needles in him unless there was a change in condition in the baby. A NICU observation chart is presented for child A, including the respiratory rate. Mr. Myers says the readings are, quote, not stable. Dr. Evans disagrees, saying the readings are, quote, within range. The increase in the respiratory rate readings were down to the insertion of the long line and UVC, handling of the baby and a heel prick procedure which caused the baby discomfort. Dr. Evans said he would expect the heart rate to go up with an increased respiratory rate, which would be a concern. But as the heart rate had remained stable, he said he would not be concerned and child A was not even requiring oxygen, with saturation levels at about 97 to 99%, quote, was about as good as it gets. Dr. Evans says it happens that children on neonatal units can go without fluids for 4 hours. He said it was not ideal and unfortunate, but it did not make a clinical difference in this case. He said a child which had missed out on that level of fluids for that time would not have subsequently collapsed and died. Dr. Evans reiterates that the context of other readings had all the markers of a stable baby. This was a baby who was stable prior to him collapsing, he said, referring to the words other doctors have made in evidence. Dr. Evans dismisses alternatives put forward by the defence, including infection, saying such evidence would appear on a post-mortem examination. He dismisses a suggestion of a rapidly spreading infection in the baby as ridiculous, as he said such evidence would again be found post-mortem by a pathologist. Dr. Evans said his conclusion of an air embolus was based on a baby suddenly crashing and, more significantly, followed by resuscitation, which was unsuccessful. He adds the subsequent X-ray and skin discoloration reports had firmed his opinion. He said, quote, "A collapse of this speed in a baby unit with full medical care is very unusual these days." He adds that child A, given all the factors, is normal and in the safest place on the planet for their needs. Neonatal unit care is as good as it gets, he said. It has come on leaps and bounds over the years. Mr. Myers, on behalf of the defence, says skin discoloration can be a sign of illness or due to underlying circulation problems or infection or blood pressure issues secondary to something else. Dr. Evans agrees. Mr. Myers asks if it would be flawed to diagnose skin discoloration as an air embolus. Dr. Evans replies, "Discoloration is a general term, noting there is something present on the skin, as noted by a doctor or nurse. You can't say it is due to a specific condition." Mr. Myers refers to a 1989 study which showed following 50 cases involving an air embolism, only 11% involved skin discoloration. Dr. Evans said he had come to his initial conclusion of an air embolus for child A before becoming aware of the skin discoloration. The judge rephrases a question of Mr. Myers to ask that, quote, "Failure of resuscitation of itself and in isolation is not a consequence of an air embolus." Dr. Evans agrees. He says in combination with all factors already presented, including air in the great vessels, sudden collapse and skin discoloration, the conclusion is that of an air embolus. He says an air embolus is not common but is rare and unusual. Dr. Evans said in 14 of the 17 cases he had completed his preliminary reports by November 2017 and was unaware of any medical staff member being a suspect. He became aware of the name LucyLetby for the first time upon her arrest in July 2018 when he read her name in the press. He said he was the first to come up with a diagnosis of an air embolus, and this had been agreed by a peer review by Dr. Sandy Bowen, plus by a medical expert who began to peer review his reports, but sadly before completing the review became seriously unwell and died. Mr. Myers asks about the non-fatal collapse of child B, who needed breathing support at birth, as clinical notes shown to the court shows. An X-ray review has the note RDS type picture, as also shown for child A. Dr. Evans agrees with Mr. Myers that a child such as child B is prone to desaturations. Mr. Myers presents a clinical note to the court from June 19th, 12 days after child B was born, noting there were desaturations recorded, and on June the 20th, when the apnea alarm went off on 3 occasions, with oxygen saturation down to 70 to 80% on each occasion. A paediatric assessment dated July the 14th for child B is presented to the court, in which breathing problems are noted along with mottling. Mr. Myers states, "There are some respiratory issues associated with her health." Dr. Evans replies, "Nothing compared to what we would call the index event, the collapse. She needed resuscitating." Mr. Myers asks about the differential diagnosis for child B, concluding there was either an air embolus, suffocation, or someone had removed the prongs on purpose. Dr. Evans said in his opinion he was on the ball from the start in considering an air embolus. He said his opinion was reinforced by colour changes every 10 seconds, as mentioned by a Countess staff member in court. The theory of removing CPAP prongs on purpose is discussed. He says it's possible for a baby to move them by accident. He is asked if smothering is a possibility, to which Dr. Evans says he has since discounted. Mr. Myers, on behalf of the defence, said it is a key aspect that the inability to successfully resuscitate child A had led to an air embolus. He adds that child B recovered, and that is inconsistent and contradicts the air embolus theory. Dr. Evans responded, "No, it does not. We cannot do studies where we inject air into babies and see what happens." He adds that the volume and speed at which the air is injected, along with the skill of the resuscitation attempts, can make a difference as to whether the baby survives or dies. Dr. Evans says, under questioning by Mr. Myers, he would be happy to hear of an alternative explanation from a medical perspective for child B, but he is happy with the conclusion he has made for child B that she has had an air embolus. The prosecution refers to the clinical note from June 20th, following the desaturations recorded. The note adds child B, quote, self-corrected. Dr. Evans replies, "It's a bit frightening, but she self-corrected. These things happen in babies." He reiterates that those events noted on June 20th are a long way from what happened when child B suffered a non-fatal collapse. Dr. Sandy Bowen is now giving evidence in respect of child B. She confirms she has examined medical records, case notes and photographs for child B, and peer-reviewed Dr. Evans' report for a non-fatal collapse in June 2015. Child B collapsed at 12:33 a.m. on June 10, 2015 at the neonatal unit. She later recovered and 4 weeks later was discharged from the Countess of Chester Hospital. Dr. Bowen says child B was compromised at birth and required respiratory support, which was not that unusual for someone of her prematurity. She stabilised very quickly, Dr. Bowen added, and was in air with normal blood gases and stable enough to have skin-to-skin contact with her mother and for feeds to be started. Dr. Bowen said the circumstances of child B's collapse were not normal, but, quote, very concerning. She said, quote, despite being on CPAP, she was otherwise normal. If such babies deteriorate, there is normally prior warning, but there was nothing to suggest she was going to collapse in this way. The prosecution referred to an event where the nasal prongs were dislodged prior to the collapse. Dr. Bowen said the prongs can be misplaced and the babies are probably quite uncomfortable, and if left for a prolonged period of time, there would be a desaturation with prior warning. She added, quote, it was noted, the prongs were replaced and everything went back to normal. Dr. Bowen replies to the question if the misplaced prongs had anything to do with the subsequent collapse. Quote, no, none at all. Dr. Bowen said other factors such as infection or cardiac arrhythmia could be discounted, and the only conclusion left was air embolus. She refers to the skin colour changes seen on child B, and how florid and different it was from anything they had seen before. She said, quote, it just didn't fit with any other potential different causes. Dr. Bowen said she looked at child B's case on its own merit, as with any other when coming to a conclusion. Ben Myers KC for Letby's defence is now asking questions to Dr. Bowen. Mr. Myers asks if it is important that medical experts have current day-to-day experience in a medical environment. Dr. Bowen replies, not necessarily, no. What you can't do is dispel the experience they have had over many years. She adds that it is not crucial that they have on-the-job current day-to-day experience. After further questions, she said such experience would be advantageous. Mr. Myers refers to GMC guidance in giving evidence as an expert witness and asks if someone who retired from clinical practice is still in the same position to give evidence for events which happened in 2015. Dr. Bowen says someone does not lose their knowledge after retiring from on-the-job clinical practice, especially if they keep up to date with clinical practice, they are not at a disadvantage. Dr. Bowen said the first time she had contact with other medical expert Dr. Evans was earlier this year. This was to discuss one of the cases in the trial via a telephone conversation, as there had been a difference of opinion. Dr. Bowen said she had previously seen one example of an air embolus and it was in a neonatal case, but was, quote, very long ago. She said she could not recall the specifics of the case, but the air bubbles seen in the imagery were, quote, very striking. She said she had formed her views after excluding other possibilities. Dr. Bowen said she is unaware of any genetic condition which would cause a baby to collapse and die within 24 hours. She said genetic screening would only be done if staff had a suspicion the baby had a genetic condition. Mr. Myers says Dr. Bowen said child A was, quote, extremely stable prior to collapse. She said there was, quote, nothing which was cause for concern. The blood gas record for child A is shown, and Dr. Bowen says the lactate number of 2.6 to 2.7 is slightly elevated. A normal reading at the Countess was 2, but this has to be taken in context with other parameters which were normal. The NICU observation chart is shown to the court for child A. Mr. Myers says the respiration rate is not stable. Dr. Bowen says it's above the normal rate, but it is stable. She said the range is 60 to 80 breaths, which is outside the normal range, but with CPAP breathing support and in air. She said during the afternoon there would have been interventions which would have caused the respiration rate to rise. She said the respiratory rate, in conjunction with other factors, would have been something staff would have been aware of. Mr. Myers asks, would you say this was an alert? Dr. Bowen replies, yes, but there was nothing else that needed to be done. He wasn't having a lot of desaturations. The next step would have been to ventilate him and he didn't require that. Dr. Bowen states, handling in a baby with respiration support can make the respiration go up. Mr. Myers asks if the heart rate would also go up. Dr. Bowen replies, it can do, but not necessarily. Mr. Myers refers to the insertion of the UVC and long lines. Dr. Bowen said the long lines were not in the best position, but was in a fine position that was safe and would not cause problems with the heart. Dr. Bowen said a long line can move if left in for 2 weeks or more. She said the long line would not have moved in the space of a day, and the recommendation is not to x-ray every day. Mr. Myers refers to child A's lack of fluids for 4 hours. Dr. Bowen said it was not okay and would not be optimal care, but he had no IV access and the doctors had to prioritise other matters on duty. She adds it wouldn't cause a sudden collapse like with child A. The only deterioration he could possibly have would be a drop to his blood sugar. Mr. Myers asks, would you agree the whole situation is suboptimal at that moment? Dr. Bowen responds, no. Mr. Myers asks if the lack of fluids means the whole situation is suboptimal for child A. Dr. Bowen replies, no. Mr. Myers refers to the skin discoloration. Dr. Bowen explains there is a difference between a rash such as chickenpox and changes to colour in the skin where it can go blue or pale or mottled. Mr. Myers refers to a paper published by the International Journal of Critical Illness and Injury Services on air embolisms, which reports air can enter via the UVC during negative pressure in the vessel systems. Dr. Bowen says she knows this sort of thing can happen, but in adults, and is not aware of any neonatal cases. Mr. Myers now refers to the case of child B. He says the UVC procedure had to be repeated with her. He asks if that was suboptimal. Dr. Bowen replies, No, but ideally you would want it in the first time. A clinical note refers to child B not getting fluids for a couple of hours. He asked if that was suboptimal. Dr. Bowen agrees. Mr. Myers refers to a clinical note showing it took 5 attempts to insert a long line for child B and asks if that was suboptimal. Dr. Bowen replied, 5 attempts is what it took. It's incredibly difficult to sight these. They are 1 millimetre wide. At times it just won't thread for you. You are very aware that you are handling this baby, and the easier thing to do is to take it out and reinsert it. She adds, rather than fiddling about with it in the baby's body. Dr. Bowen agrees there were breathing problems for child B at birth. Mr. Myers asks, do you agree that child B could deteriorate without deliberate harm? Dr. Bowen replied, it is a possibility. Mr. Myers asks, air embolus is usually fatal, isn't it? Dr. Bowen agrees there is a risk. Dr. Bowen says a small quantity of air could create an air embolus. She said it is the volume and speed which are the factors. Mr. Myers says it is almost always fatal. Dr. Bowen replies that can be the case with adults, to which there have been medical reports published. A clinical note refers to the purple blotching pink and active for child B and is shown to the court. Mr. Myers asks if pink and active refers to the baby. Dr. Bowen replies, yes. The prosecution, led by Nicholas Johnson KC, is clarifying a few matters from Dr. Bowen's evidence. Dr. Bowen said she needs to be completely independent and base her conclusion on the evidence presented to her. The blood gas record is shown to the court. Dr. Bowen says one of the parameters from a blood capillary reading, a PO2 recording, is typically disregarded as it is not reliable. Dr. Bowen presents a UVC to the court and explains how it is administered and left so there is no air left in the tube. She explains a long line looks similar but has a wire inside it. Dr. Bowen clarifies she has never heard of a case in clinical experience or in educational courses or in published literature of a neonatal having an air embolus as a result of negative air pressure as described in the medical paper concerning air embolisms in adults. Dr. Bowen is asked if there is any link between child B not getting fluids and the collapse which happened 20 to 30 hours later. Dr. Bowen replied, no. A note dated July the 14th relays a progress report for child B. Mr. Johnson asks if there is any evidence of breathing problems in that note. Dr. Bowen says, there isn't. Dr. Bowen says the colour change on its own is not diagnostic of an air embolus, but needs to be taken into context with the sudden and unexpected collapse. Nicholas Johnson KC for the prosecution explains to the jurors he will now read a summary of the police interview LucyLetby had in respect of child A and child B. The wording of the summary has been agreed between the prosecution and defence. For the case of child A, the first interview took place in July 2018. Letby was allowed to look through the case notes and was asked if she remembered the specific shift. She replied, yes. Letby gave details of the handover and the long line administration. She said she checked the fluids and the nurse colleague had the bag out. She said they noticed child A was pale and mottled and a crash call was put out. She said full resuscitation attempts followed. She said child A had been a little bit jittery in appearance and believed that was due to low blood sugar levels. She said a colleague was there with the fluids at the handover. She said child A went pale after a colleague had connected the fluids. She said child A had, quote, gone pale about 5 minutes after the fluids were administered. She said child A had a rash-like appearance, which Letby put down to the result of an infection or being cold. Quote, he was more pale than the areas of the mottling. She was asked if anyone else had seen the mottling. Letby replies, yes. She said they were advised to stop administration of the fluids. Child A was then not breathing and Dr. Harkness was called over. Letby said she could not recall child A's resuscitation, but recalled Dr. J-Ram had entered the room. She said the death of child A, quote, had been difficult for her, and said there was a support network among the nursing team. She said she could not recall who attached the fluids line, but believed it was her nursing colleague Melanie Taylor who had connected the fluids. She said photos were taken of child A in accordance with the parents' wishes on their phone, along with a lock of hair and hand and footprints. She agreed she had been taught to prime lines so air could not get in them. She denied having done so via child A's long line or UVC. She said she didn't know exactly what an air embolism was. She said her relationship with the child's parents was, quote, strictly professional and could not explain or remember why she had searched the mum's name on Facebook several times in the following weeks. She explained for a later search she may have been searching for their names for an update on child B. For child B, Letby explained the discoloration was a different appearance to that of child A. Child B's appearance was observed before resuscitation attempts began. She did not recall having had any concerns for child B or any alarm going off for her. She confirmed she would have handled child B to an extent for medication and to attach lines. She said she did not recall how upset child A and B's parents were at the time. The jury is now being walked through the sequence of events for child C, with the evidence, as was for the case for child A and B, being shown on an interactive display to the court. The electronically stored evidence is also available to view on the jurors' iPads. The jury is informed that, as they are increasingly used to the system and descriptions of types of medical records, this process will go quicker than that for child A and B. Text messages exchanged following the deaths of child A and B show LucyLetby asking if there were any spare shifts going, adding, quote, think I need to throw myself back in on Saturday. The response, hopefully it might settle down by then. Letby, I think from a confidence point of view I need to take an ITU, intensive treatment unit, baby soon. The response, it does knock you a bit when things like that happen, but it's okay to have some time out as well. Enjoy the sun. The court is shown the nursing night shift for June 13th, with a different nurse identified as the designated nurse for child C and Letby being a nurse for two other babies. A message sent to Letby on June 13th at 9:48 PM says, "You okay?" Letby replies, quote, "I just keep thinking about Monday. Feel like I need to be in room 1 to overcome it, but nursing colleagues said no." The colleague responds, quote, "I agree with her. Don't think it will help. You need a break from full-on ITU. You need to let it go, or it will eat you up." Letby responds, "Not the vented baby necessarily. I just feel I need to be in room 1 to get the image out of my head." Letby adds, quote, "It probably sounds odd, but it's how I feel." The colleague responds, quote, "Well, it's up to you, but I don't think it's going to help." After further messages are exchanged, the colleague suggests, quote, "Why don't you go in room 1 for a bit?" Letby responds, quote, "Yeah, I have done a couple of meds in 1. Letby later adds, quote, "Forget I said anything, I'll be fine. It's part of the job. Just don't feel like there is much team spirit tonight." The colleague replies, quote, "I'm not going to forget, but I think you're way too hard on yourself." Letby referred to previous events she had seen in a women's hospital and the support available following such events. The text message conversation on WhatsApp concludes at about 11 PM. Child C collapsed 20 minutes later. Text messages and WhatsApp messages sent to and from Letby's phone the morning after child C died are shown to the court. Letby messages a colleague, quote, "Sorry, I was just off last night. Was not a great start to the shift, but sadly it got worse." The colleague responds, quote, "You weren't off, you were just not happy, and there's nothing I could say that was going to make it any better." Letby replies, quote, "I was struggling to accept what happened to child A. Now we have lost child C overnight and it's all a bit much." The colleague replies, quote, "It will be, but it does happen to these babies unfortunately. It's a very sad part of our job." The colleague recalls a baby who had previously died in a neonatal unit but had overwhelming sepsis, so nothing would have saved that baby. Letby responds, quote, "Child C is the little 800-gram baby. Went off very suddenly. I know it happens, but it's so sudden." Messages are relayed detailing how nursing staff on the night were upset by what happened. Letby's colleague messages, quote, "This is where we have to pull together and look after each other." Letby replies, "Think we support each other brilliantly. Just such a shock, especially after Monday." Letby is advised to, quote, "switch off for a bit." Letby messaged her mum that morning to say, quote, "We lost a little one overnight. Very unexpected and sad." Letby added in the message to her mum, quote, "He only weighed 800 grams. New girl was looking after him. She is devastated." Letby's colleague in a message to Letby said, quote, "Hoping you are going to be okay. This is not like you. Sending the biggest hugs." Letby in her reply says, "It's heartbreaking, but it's not about me." Letby's colleague in her reply says to use a northern phrase, "Chin up, Chuck, we will get through it together." Letby replies, "It's not about me or anybody else. It's those poor parents who have to walk away without their baby." Letby messages another colleague asking when she is next working, before adding, quote, "We lost little child C overnight. Everyone's devastated." The colleague responds, quote, "Damn, infection? Crap week. How is child B?" Letby gives an update and says for child C, quote, "It happened very quickly." The colleague responds, "Damn, as quick as child A? Yeah, shit week." Letby messaged a colleague, quote, "Parents sat with child C in the family room, persuaded them to have hand and footprints, but they just wanted to go home." The colleague replied, "That is so sad, don't know what to say." Letby responds, "There are no words, it's been awful." The colleague replies, "It's a really tough week, especially for you." The conversation ends at 10:12 a.m. Letby searched for both the parents of child C on Facebook later that day at 3:32 p.m. A conversation Letby has with a third colleague later that day is shown to the court. Letby, quote, "I don't really want to go in tonight." The colleague responds, "I don't particularly, but we will get each other through it." Letby responds, "We are a good team and we will get through it. You did so well." The colleague replies, "We all did. So lucky to work with such an amazing and supportive team." The court is now hearing evidence from Dr. Sally Ogden, who in 2015 was a paediatric registrar at the Countess of Chester Hospital. Child C was born at 3:31 p.m. on June 10, 2015, with Dr. Ogden confirming she was present at the birth and facilitated the baby boy's transfer to the neonatal unit. Child C was, quote, "smaller than expected for that gestation, with a C-section made necessary." The birth weight of 800 grams was within the range for child C to be allowed to be treated at a level 2 neonatal facility, the one at the Countess of Chester Hospital. An APGAR score recording how well the newborn is doing immediately after birth is noted, rising from 7 to 9 out of 10. A clinical note showed there were, quote, "no RF risk factors for sepsis, and child C was born in good condition, came out crying, good respiratory effort, no resuscitation needed, pink, well perfused. The heart rate was under 100, the saturation was 95% air." Dr. Ogden said those latter two readings were what would have been expected. Upon arrival to the neonatal unit, Dr. Ogden noted symptoms child C was starting to struggle breathing, including grunting and subcostal recessions. The note added, quote, "decision to intubate," which Dr. Ogden said would have been her decision. The respiratory signs can change quite quickly after birth, Dr. Ogden says, so such support for babies of child C's preterm would not be unusual. Ventilator support was set up for child C with, quote, "standard settings for the context set up on the machine." A note of medical communication with the parents is shown to the court. Dr. Ogden's colleague recorded observations taken by her, relaying to the parents that child C was born in a good condition with good breathing. Another clinical note showed a 10% dextrose solution would be administered via a TPN bag through a UVC. A note on a discussion between the hospital and the Liverpool Women's Hospital was made due to child C's weight. The discussion would have raised the possibility of child C being transferred to Liverpool. The clinical note regarding a possible transfer for child C concludes, quote, "happy for patient to remain at Countess of Chester Hospital at present, if clinical concern overnight for rediscussion with Liverpool Women's Hospital." A clinical note dated the 11th of June 2015 at 11 a.m. is made by Dr. Ogden with a number of medical observations. They include details of the respiratory support and feeds. Dr. Ogden says child C was on CPAP support by this time, on 41% oxygen, a, quote, "moderate amount for a preterm baby, with other readings being normal." There was an increased breathing rate noted. Child C's blood sugar levels were stable. Child C was screened for sepsis and placed on antibiotics as a precautionary measure. There were no concerns on the cardiovascular system. Child C was observed to be active, pink, well perfused, with chest clear, slight increase in work of breathing. Other observations were recorded as normal. The overall picture was Child C was responding as to be expected. The prosecution say a generic plan of next steps was put forward for Child C, to which Dr. Ogden agrees. Another note by Dr. Ogden on June 13th at 9:30 am is made for Child C. The list of problems is noted, including RDS and suspected sepsis. Dr. Ogden says the oxygen levels had gone down on CPAP to 26%, as had the lactate reading. Child C's breathing was stable and possibly improved. Very dark bilious aspirates are noted from the feeding section. This was, quote, not normal and suggested a problem with his abdomen or a sign of how Child C's bowels were responding to being preterm. That would have been a concern, Dr. Ogden said. Child C had a long line put in place by this time. Other observations made included that chest was clear with no increased work of breath. The abdomen was soft, not distended, which Dr. Ogden said was a reassuring sign amid a concern from Child C's aspirates that a gastrointestinal disease NEC was a possibility. The reviewing doctor suggested to hold off feeds for now and review in the afternoon if the aspirates did not get any worse. Ben Myers KC for Letby's defence is now asking questions to Dr. Ogden. He refers to the decision about which hospital Child C should have been placed in. Liverpool Women's Hospital offered Level 3 neonatal care, with the Countess of Chester Hospital offering Level 2 care at the time. Dr. Ogden said she believed the minimum weight for Level 2 care centres to treat babies was 800 grams, the birth weight of Child C. Mr. Myers said he was right on the borderline of what would be accepted at the Countess. Dr. Ogden replied, yes. Mr. Myers refers to the conditions detected that led to the C-section. He asks if one of the conditions that could follow would be NEC. Dr. Ogden agrees. Mr. Myers said for such babies there would be an increased risk of infant mortality. Dr. Ogden agrees. She also agrees that Child C would be a high-risk baby. She says that for the context and taking the considerations for those conditions into account, Child C was in a good condition. Mr. Myers refers to the APGAR score for Child C at birth, with readings at 1 minute, 5 minutes and 10 minutes. Child C scored 7 out of 10, 9 out of 10 and 9 out of 10 respectively. The scores are subjective and based on observations. Mr. Myers asks about the clinical note which refers to the discussion between the Countess and the Level 3 Liverpool Women's Hospital. Mr. Myers, quote, at this early point, your view was that Liverpool Women's Hospital needed some communication in relation to whether Child C would need to be transferred? Dr. Ogden replied, yes, that's right. Mr. Myers says if Child C had other problems along with a borderline weight, then that may affect the decision to transfer a baby to a tertiary centre. Dr. Ogden replied, potentially, it would depend on the circumstances. Dr. Ogden said the decision to transfer would be a joint one made between the hospitals and made via consultants. Dr. Ogden said if Liverpool Women's Hospital could not accommodate a baby, there would have been other tertiary centres available if necessary. Mr. Myers says the Countess would have required sufficient numbers of staff to care for Child C. He asks if June 2015, quote, was a particularly busy time for the neonatal unit in Chester. Dr. Ogden replied, yes. Mr. Myers said with the number of babies, another factor would be the individual care required for each baby, which included a number of preterm babies in June 2015. Mr. Myers asks about the risk of infection, which Dr. Ogden states was not an immediate concern at the time of his birth. Mr. Myers says infection is, quote, always a potential risk. He asks about the breathing issues Child C had at birth, and asks whether such issues could be a sign of infection. Dr. Ogden agrees. The court is shown an X-ray review in which a staff member had noted, quote, hazy left lung field. Dr. Ogden said she hadn't seen the X-ray, but agrees the note in the review means there could be a sign of infection. The the list of problems in a clinical note is raised, including suspected sepsis. Dr. Ogden says there was a treatment plan in place for suspected sepsis. The high lactate noted is an indicator of a potential non-specific issue with the baby, the court hears. The clinical note from June 13th is raised. Mr. Myers suggests there are increased issues for child C. Dr. Ogden replies, "It's hard to say." Mr. Myers refers to the very dark black aspirates, and Dr. Ogden agrees they are a cause for concern. Mr. Myers asks if the aspirates are a red flag warning sign. Dr. Ogden replies, "It's certainly a worrying sign which would need more investigation." A nursing note is presented which showed child C's weight by June 13th had dropped to 717 grams. The note adds, "Doctors aware." Mr. Myers says if that was the weight of child C at birth, he would not have been cared for at the Countess. Dr. Ogden replies, "I don't think so, no." Dr. Ogden agrees at this point there would have been some concerns with child C, and he would have needed close monitoring care. That concludes Dr. Ogden's evidence. Dr. Gail Beach is now being called to give evidence. In June 2015, Dr. Beach was working at the Countess of Chester Hospital as a registrar. She confirms working day shifts on June 11th and 12th and had involvement with child C and his parents. She confirms she carried out an ultrasound scan for child C on June 11th and the reviewing doctor recorded NAD, which stands for No Abnormalities Detected. Dr. Beach's note, made on June 12th at 10:15 a.m, is shown to the court. She recorded from data child C was on CPAP, 30 to 40% oxygen assistance. The saturation levels for child C were 91 to 98%, with no documented desaturations. Gases were satisfactory. It looks like he was pretty stable on those CPAP settings, Dr. Beach tells the court. The gases refer to the blood gases. The urine levels were slightly high, but not concerning yet. Under the heading sepsis, a CRP reading going up was something to be aware of, but not a huge rise according to Dr. Beach, and a note awaiting lumbar puncture was made. The lactate reading recorded is 1.8 to 2.8. Dr. Beach says 2.8 is high but had been falling from a higher number. Dr. Beach said there was nothing there on the clinical chart numbers which was worrying, with a few readings being something to be mindful of. He was a nice, stable baby, as he had been allowed out of his incubator to be allowed skin-to-skin contact with his mum, Dr. Beach added. Dr. Beach said the UVC had come out of child C during a previous shift and a note was made for a long line to be inserted later. The follow-up note showed Dr. Beach had inserted the long line under sterile conditions and was secured in at the third attempt, with the note, "Happy with position, patient left comfortable." An X-ray of child C, timed at 12:36 p.m. on the 12th of June, shows the long line having been inserted. An X-ray review recorded in the comments, "Large stomach bubble, gaseous bowel." Dr. Beach said this wouldn't be a huge concern given child C was on CPAP. Dr. Beach reiterates there were no significant concerns for child C at that point, but there were matters to be mindful of. Mr. Myers now asked Dr. Beach questions on behalf of LucyLetby. The 3 attempts to insert a long line from a clinical note are shown to the court again. Mr. Myers asks if there is a guide to the number of attempts or who should administer them. Dr. Beach said it would be a procedure by a doctor, not a nurse, and would be done by the most junior doctor present to get them experience, subject to availability and the complexity of the procedure. Dr. Beach said there was an unwritten rule. A registrar would have 2 or 3 attempts before escalating the procedure to someone more senior. Dr. Beach explains the note "flushed" is made as confirmation the long line has been flushed to ensure there is no air in it. The X-ray of child C with the long line in is presented to the court again. The dark areas in the stomach and bowel areas refer to air inside the body. It is compared to an X-ray taken of child C at birth where there was also a pocket of air in the stomach. Dr. Beach noted from the June 12th X-ray it was very gaseous and the result of CPAP. Mr. Myers asks if that could also be termed CPAP belly. Dr. Beach says it could. The court is now hearing evidence from Yvonne Griffiths, who was the Countess of Chester Hospital Neonatal Unit Deputy Manager in June 2015 and a senior nursing practitioner. An admin error had resulted in Miss Griffiths' notes for Child C being written in the file for a different child, but the error was spotted and rectified quickly. The note is written on June 14th on reflection notes from June 12th with care from 8 AM that day. The notes record assistance with ventilation by NCPAP, with oxygen levels varying from 37% to 25%. Child C was unsettled at times. The long line was administered at 6:30 PM. Bile noted on blanket. Miss Griffiths said with any baby there is a worry of introducing feeds too early. On this occasion, bile came out spontaneously. Miss Griffiths said the nasogastric tube was aspirated as a matter of procedure and 2 ml of black-stained fluid appeared. Child C was too unsettled for a lumbar puncture, planned to reassess later. Miss Griffiths said they would not want to take the risk if the baby was too active, as a lumbar puncture would involve a needle. Miss Griffiths added she came in the morning after Child C had died to assist staff. Mr. Myers, on behalf of the defence, says Child C was at the limit for weight for being accepted into care at the Countess of Chester Hospital. Miss Griffiths had said in a police statement the hospital did not often care for babies of that weight. She tells the court there is a decision to be made whether the baby is suitable to be cared for at the Countess or risking transfer to a tertiary centre, and that is made following consultation. Miss Griffiths said in the police statement, quote, "It was very uncertain what the outcome would be for Child C. She confirmed she was the designated nurse for Child C on June the 12th. She also confirms Letby was not in the unit that day." Mr. Myers talks through the nursing notes from the previous night shift for June 11th to 12th. At that point, no bile aspirates had been recorded. He refers to a note about Child C requiring an increase in oxygen when handling as Child C was desaturating. Miss Griffiths says, in relation to the air in the stomach, the nurses, quote, "did everything they could through the nasogastric tube to aspirate air." The note referring to bile found on the blanket and 2 ml of black-stained fluid being aspirated from June 12th at 6:30 PM is referred to. Mr. Myers asks if dark bile is a matter for concern. "Any bile is a matter of caution," Miss Griffiths replies, and feeds would have been stopped as a precaution. She added Child C did not desaturate when vomiting a small amount of fluid. She agrees it was important for close monitoring on Child C. Mr. Myers says, "It's potentially serious, this issue, isn't it?" Miss Griffiths replies, "Yes, and I did get the doctor to review." The first witness to give evidence today is Joanne Williams, who previously gave evidence in an agreed evidence statement for the case of Child A and Child B. The court is reminded she was a neonatal nurse in June 2015. Miss Williams recalls she was the designated nurse for Child C on June the 13th and had cared for him prior to that day. She said that particular day shift was not too busy. She recalls Child C was small and premature and weighed 800 grams at birth. A nursing note made by Miss Williams is presented to the court, written retrospectively at 4:19 PM on June the 13th, showing Child C was on NCPAP with 23 to 26% oxygen, quote, "a minimal amount of oxygen." Miss Williams said that was a good sign. A blood gas reading was very good at 9 AM, but Child C was noted to be very unsettled and fractious, which Miss Williams tells the court was not that uncommon for a baby of his size. The note adds Child C was allowed to be taken off CPAP to have skin-to-skin contact with mum. Miss Williams says such contact is extremely powerful for a newborn baby and is really beneficial for them. The note adds Child C, quote, "calmed down straight away while on mummy, just required some facial oxygen while out. No signs of increased work of breathing." Child C was weaned off CPAP for 2 hours and placed on Optiflow at 1 PM, as it was noted the baby was so unsettled on NCPAP. The court hears Optiflow is a less invasive form of breathing support than CPAP. Child C was, quote, "very settled this afternoon, with a slight increase in respiratory rate." A further blood gas reading was taken later in the afternoon, with readings, quote, not quite as good. Miss Williams said this was something to take into consideration and had followed child C being placed on Optiflow. The note adds, quote, clinically remain stable but aware do not want to push child C. Miss Williams said fluids were increased with 10% dextrose discontinued as it was day 4 and the dextrose would not have been needed with lipid fats increased to support nutrition. The note adds, quote, continues to have dark bile aspirates frequently this morning. Miss Williams says it's not reassuring as it could be a sign of NEC, a gastrointestinal disease. Philip Asprey, prosecuting, says, was it of concern? Miss Williams replies, yes. It was escalated to an on-duty doctor that day. Miss Williams says child C was on nil by mouth and a cautious feeding regime. The court hears child C had pulled out 2 oral gastric tubes during the morning due to being, quote, feisty and unsettled. A nasogastric tube was on free drainage to drain air from child C, reducing air build-up in the stomach and to check for any aspirates. The note adds, quote, abdomen full but soft. The court hears that was quite normal for a baby, for child C. The abdomen had a slight shine but not veiny or distended. The court hears a distended abdomen would be a symptom of NEC. The note adds, quote, if aspirates improve, can start tropic feeds this evening. Rantadine was administered via an IV to counteract the bile aspirates. The weight of 717 grams was noted, which Miss Williams says is not unusual as all babies lose weight in the first few days. She said doctors were aware of the weight update. A cranial ultrascan was carried out with no abnormalities detected. An intensive care unit chart for child C is now presented to the court, which details the various readings and notes corresponding to Miss Williams' nursing note. The aspirates of dark bile are recorded at 9 AM and 1 PM. 0.5 ml dark bile is recorded at the latter, which was a small amount, but any dark bile was a concern, Miss Williams says. A further 0.5 ml of dark bile is aspirated at 4 PM. A nursing note of family communications from June 13th is shown to the court, written by Miss Williams. She records, quote, Mummy and Daddy on the unit during the day. Both have had skin-to-skin contact with child C. Pleased to see him more settled this afternoon. Appear happy with plan of care. A further nursing note showed a blood gas reading at 6 PM was, quote, improvement from previous CBG, but lactate levels had increased. Child C remained on Optiflow and was stable. The aspirates were reduced this evening. The note adds, quote, question mark, commence enteral feed tonight. Miss Williams clarifies that means query. Miss Williams said you would always be cautious of a baby that size, referring to child C. Mr. Astbury, on behalf of the prosecution, says, how was the progress during that shift? Miss Williams replies, he had done well, weaned off to Optiflow, he had benefited from time with mum and dad. Ben Myers KC for Letby's defence is now asking Miss Williams questions. She agrees that you can never be complacent with a child like child C, and however stable he is, he would require close monitoring. She said it was important to carry out observations and look for subtle signs. Mr. Myers says the observations for child C need to be taken into context for a baby of the size of child C. Miss Williams says that could potentially be the case. She adds she was aware of pre-existing concerns raised at child C's birth. Mr. Myers asks if child C still needed breathing support with Optiflow and would not have been switched if he had been settled on NCPAP. Miss Williams says he had good blood gases so was able to step down respiratory support to Optiflow. Mr. Myers says, you are documenting all the little changes made on the nursing notes because he is such a little baby, is that right? Miss Williams replies, it is important to be thorough. The note of, quote, aware do not want to push child C is raised. Miss Williams states, it's making sure we are doing individual care and very aware of what's happening with child C and what he needs. Not wanting to push child C was not to tie him and or administer procedures such as a lumbar puncture. Miss Williams said not wanting to push child C in this context was in relation to breathing. Mr. Myers said, could that apply to feeding as well? Miss Williams replied, yes. The matter of dark bile aspirates is mentioned. Mr. Myers says, "We have seen from the chart that aspirates have been taken throughout the day, and they have been there the day before?" Miss Williams replies, "Yes." A distended abdomen could be a symptom of other conditions, Miss Williams adds, but NEC would be one which would be of concern. The tropic feeds, as mentioned on the nursing note, would be via expressed breast milk if the aspirates improved, along with the overall clinical picture, Miss Williams tells the court. The weight of 717 grams is a significant reduction, isn't it? Mr. Myers asks. Miss Williams says it would need to be taken into context and it was important to administer the feed safely. The plan to do so would be, following a discussion, to commence enteral feeds that night. Mr. Asprey, on behalf of the prosecution, rises to ask one more question on CPAP. Quote, "Would you ever take a baby off CPAP just if they were unsettled?" Miss Williams replies, "No." The court hears the step down to Optiflow would be done in consideration with other factors. Miss Williams has now finished giving evidence for child C. The next witness to give evidence in court is Sophie Ellis, who was working as a neonatal unit nurse in June 2015. She recalls child C and first saw him when he was delivered as an observer learning in the nursing role. She said she was on duty for the night shift of June 13th, starting at 7:30 a.m, ending at 8 a.m. the following day. She said she was allocated to look after child C for that shift on her own, with support from another staff member as she was junior in her role. The nursing staff roles for that shift are presented to the court, with Miss Ellis, the designated nurse for child C, and LucyLetby looking after two other babies in a neonatal unit. She said she was aware child C had been moved to Optiflow and knew the subject of feeds was a topic being discussed. Hopefully they were going to start feeds. Her nursing note is shown to the court, showing care taken over at 8 p.m. Quote, "Safety checks completed and fluid requirements calculated. Optiflow in 25% oxygen, observations satisfactory, respiratory rate elevated at times as previously been for past few days. Pink and well perfused, active and alert. The fluid dose is stated due to birth weight of below 1,000 grams. The long line site was satisfactory. A blood gas reading was taken at 2 a.m. Trophic feeds were agreed to be started." Miss Ellis said she was not present for the first desaturation as she had left the room. A discussion on trophic feeds was had before 11 p.m, with the feed administered at 11 p.m. Miss Ellis said, quote, "There was nothing particularly striking about the care for child C between 8 and 11 p.m. He was doing well and was feisty at that time." A retrospective note written by Miss Ellis says, "Had two fleeting bradycardias, self-correcting, not needing any intervention, shortly before prolonged bradycardia and apnea requiring resuscitation." She said she had left the room, quote, "just around the corner, then the alarm went off." She said she could not recall which type of alarm it was, a lower level yellow or a more frequent urgent red alarm. She said she went into the nursery, having been out, quote, "for not a long time." She recalls upon entering, quote, "I saw Lucy standing at child C's incubator. She said he had just had a brady and a desaturation. I can't remember what she was doing at the time." After that, the brady and the desat resolved quite quickly. Miss Ellis said she didn't do or see anything being done to correct the desat and bradycardia as child C self-corrected. She added she then sat at a computer which faced a wall, with child C behind out of view. She explains LucyLetby was still in there, but not sure about anybody else. Child C, Miss Ellis tells the court, had a further brady and desaturation, which did not resolve and required resuscitation. She said when she turned around, LucyLetby was stood at the incubator. A nursing colleague had asked her to put out a crash call. Prior to administering the 11 p.m. feed, Miss Ellis said she had aspirated a tiny amount of light green bile from child C. A nursing colleague who was in the room said to put out a crash call, and Miss Ellis left the room, she tells the court. She said she left the room not for long. She said when she returned, the nursing colleague was getting ready to administer drugs and for her to continue chest compressions. She said LucyLetby was at the side of the incubator but cannot recall what she was doing. Miss Ellis said the medical team of registrars arrived along with a doctor to the unit at some point. Miss Ellis adds the parents were then informed. She said she became upset herself as this was, quote, the first time something like this had happened in her experience and she found it overwhelming. LucyLetby said to her, quote, "Do you want me to take over?" To which she said, yes. Miss Ellis said she then left the room, taking a minute to compose herself before returning to the unit to look after other babies. The nursing note says care for child C was handed over to senior nurse Melanie Taylor following the collapse. Miss Ellis reiterates that, from memory, there was nothing that concerned her about child C's condition between 8 and 11 p.m. Mr. Myers, for the defence, asks how long Miss Ellis had been working at the Countess. She replied it was since January 2015. Miss Ellis said she had not previously cared for a baby as small as child C. Mr. Myers asks, how is it that someone as inexperienced as you was given the responsibility of looking after child C? She replies, child C was very stable and I was being supported by Melanie Taylor. You were very well supported at the Countess of Chester Hospital. Miss Ellis said, quote, there was always a nurse in the room looking after child C, even when she left the room briefly. She said LucyLetby was in there and cannot recall if Melanie Taylor was also there. Miss Ellis says child C could have had 2 Braddies as they are quite common. She said she did not know whether Melanie Taylor was in the room at the time of the collapse. Miss Ellis tells the court for one of the 2 Braddies, LucyLetby was in the room. That was for the second one, but not the first. Mr. Myers refers to the 8:46 a.m. June 14th nursing note and said there was nothing prior to the 11:15 p.m. collapse. He asks why the first Braddies are not mentioned. Miss Ellis replies, I would have forgotten to write it. It was a traumatic shift. Miss Ellis says she would have added the detail of that on her subsequent nursing note. She says she does not remember if Melanie Taylor was in the room at the start of the collapse. Mr. Myers, for the defence, puts it to Miss Ellis that LucyLetby was not in there at the time of the collapse and only arrived later during the resuscitation efforts. Miss Ellis replied, I don't agree with that. Mr. Myers states, you have placed her there when you spoke to the police several years later. Miss Ellis replied, I don't agree with that. Miss Ellis has now finished giving evidence for child C. The next witness to give evidence in the case of child C is Melanie Taylor, who has previously given evidence for child A and child B. The court has shown Melanie Taylor's observation chart for child C on the night shift from June 12th to 13th, where normal readings are made for the heart and respiration rate. 2 of the readings were slightly elevated, but were normal given the context child C was on CPAP at the time. Temperature readings were stable and in normal limits, what you would expect. Other readings were considered to be normal. The handover note for the June 13th night shift is presented to the court, showing Melanie Taylor is one of the nurses on duty that night and a designated nurse for one of the babies, not child C. She confirmed she was present in room 1 that night, in the same room as colleague Sophie Ellis. She said, quote, Sophie was a very competent nurse. She was completely able to look after child C. I had no concerns with her. He had been stable. I was there for support if she needed it. Miss Taylor said her memory of the collapse was that she did not know where she was at the time child C deteriorated, but when she arrived at the incubator, LucyLetby was already there. She did not know if anybody else was in the room at that point. She recalls, quote, I think also Sophie was there as she was caring for him. Ventilation support was provided via a Neopuff device and Miss Taylor struggled to get any chest movement for child C. Miss Taylor said LucyLetby suggested using a type of ventilation support, a Gedel device, to aid child C. The Gedel device was followed by the use of the Neopuff. Miss Taylor said a crash call was put out. She added from her statement, chest compressions began before the first doctors arrived in the unit. The on-call registrar was first to arrive, Miss Taylor said. Miss Taylor recalled the chest compressions and resuscitation attempts went on for some time. Child C later died. The time of death recorded as 5:58 a.m. on June 14th. A retrospective nursing note by Miss Taylor, written a couple of hours later, said, quote, call to help as baby had Brady DSAT. When arrived to baby, baby apneic. Mr. Myers, on behalf of the defence, is now asking Miss Taylor questions about dark bile aspirates. He said child C was a stable baby, with the aspirates not being a major cause for concern. Miss Taylor said, quote, "It's not something we would initially be very worried about, but would take into consideration and act very cautiously when we find bile. I was not necessarily concerned he was unstable." Miss Taylor continues, "You have to look at the bigger picture and see what it could possibly be and see if it could be NEC and act on that, and take it as a consideration. We do encounter bile in premature babies. We would have to act appropriately, and if there are no other signs of NEC, then we would treat accordingly." Mr. Myers asks if there could be other, more immediate problems associated with dark bile. Miss Taylor said that would be a matter for doctors to examine if there was a possibility of that. There is no room for error with a baby like child C, is there? Miss Taylor agrees, and agrees there are inherent risks with treating such a baby. Mr. Myers asks about the experience of colleague Sophie Ellis. Miss Taylor responds, "You do have a foundation training in neonatal care and you would look after a baby on CPAP. New nurses have to get experience and I was supervising and she was very competent. She would not have been left alone." Mr. Myers says, "It was a very busy shift, wasn't it?" Miss Taylor replies, "Yes." Mr. Myers says Miss Taylor was not sure she was in the room when the collapse happened. "The only person you remember being there was Lucy." Miss Taylor agrees. She adds she assumed Sophie Ellis was also present. Mr. Myers says, "It is from your account Lucy is there. No one else is present. Maybe Sophie?" Miss Taylor replies, "Yes." Mr. Myers says, "I'm going to suggest you were in the nursery when this happened." Miss Taylor says she doesn't believe so. Mr. Myers says, "That it was Sophie Ellis who called you?" Miss Taylor replies, "It might have been." Mr. Myers says that LucyLetby was not there at the start of this. Miss Taylor replies, "I disagree." Mr. Myers says Miss Taylor in her police statement said she was, quote, "pretty sure she was already in nursery room 1 feeding another baby at the time of the collapse." Miss Taylor says her memory has deteriorated since then, and what is in her police statement is correct. Mr. Myers says Miss Taylor's police statement said she was called over by Sophie Ellis and there is no mention of LucyLetby. Miss Taylor said, "No, but she was there." Miss Taylor said she read her police statement for the first time this morning and had not memorised everything from it. She added, quote, "I didn't say LucyLetby called me over. I likely wasn't asked by police if LucyLetby was there. Now I've been shown that statement, I can remember Sophie called me over. Years have passed since this happened." Miss Taylor said she has not changed her mind about who was present there. "I tell you now, when I approached the incubator, she, LucyLetby, was there on the other side." She added she remembered how cool and calm LucyLetby looked at the time. Miss Taylor said she hadn't said LucyLetby was not in room 1 at the time of the collapse. Miss Taylor tells the court she didn't think it was necessary at the time to include that information of Letby's presence to police.